Hello and welcome to the Trauma Team demo lecture. I'm Mark Knights, consultant anaesthetist, and I'll be talking through this low fidelity simulation to demonstrate and talk through in slow time some examples of how to be a good trauma team. This is an unscripted simulation that was recorded a few years ago. It's not perfect and there are a few things that we forgot. When you watch these videos, see how they communicate as a team. Note what communication tools are used, like the use of standardized formats, the use of closed-loop communication, and using people's first names. Note how the team use checklists. Note how they direct information to the trauma team leader, and how the trauma team leader shares information back to the team to maintain team situational awareness and agree shared goals. Note how they anticipate needs and plan ahead. Watch also how the team are proactive and making suggestions to the team leader. The team leader is not the one making all the decisions. They are more like the conductor of the orchestra to coordinate all the team's activities. Note how the trauma team leader is always trying to maintain momentum and set goals for the team. This is what we're trying to focus on this course. Ideally, every trauma call will start with a pre-alert from the pre-hospital team. This is usually sent via control desk from WAST or from the EMERT's critical care hub, but you may sometimes be able to communicate directly with the pre-hospital clinical team. Listen to this pre-alert. Imagine you are receiving this call at work. What actions would you take?
Hello, ambulance service here. We've got a trauma call for you. We've got a 20-year-old male en route to you. The crew say that 30 minutes ago he was hit by a fan and then trapped against a wall. He sustained head, chest and pelvis injuries, and his lower left leg has been amputated. He's got a heart rate of 120, blood pressure of 150, saturations are unrecordable, and his GCS was 3. Treatments given so far: he's got a needle in his left chest and a tourniquet on his lower left leg and a pelvic binder on. The crew say they'll be with you in 20 minutes and they're asking for a full trauma team. Thank you.
If you're taking the pre-alert, always have a pen and paper next to the phone ready. Take the name or call sign and location of the pre-hospital team. Ask them to slow down or repeat if unsure, but don't ask them for unnecessary details. The pre-hospital team are going to be busy. Always write it down and use the @Mr. format. That's age, time, mechanism, injuries, signs, treatments, ETA, and resources required. After you've got this information, you need to share it with the senior clinician in the emergency department. They can then consider, do they need to put out a full trauma team call? Should they activate the major hemorrhage protocol ready? And should they call the CT radiographer in advance ready? When you respond to the trauma bleep, always introduce yourself by name, role, and your seniority. Sign in on the trauma paperwork. Don your PPE, apron and gloves. And, in COVID times, wear your face mask and visor. If tabards are available, then wear them. If not, then use stickers to identify your name and role to the team. Failing that, an effective solution is to use a marker pen to write your name and role on the front of your plastic apron, nice and legible so everyone can read it. Simple things like this can be really effective. In the heat of a busy trauma, it is nice to communicate using first names, and it's easy for all of us to forget people's names on occasion. When the team have assembled, the trauma team leader will brief the team. This is an opportunity to confirm team members' roles and check that people are happy with what is expected of them, and to brief the team on the information from the pre-alert. The team may make suggestions on what to prepare according to the pattern of injuries predicted.
Hi guys, thanks for responding to the trauma call. I'm Pete Williams, ED consultant and trauma team leader. We've been contacted by WAST with a pre-alert. We have a 20-year-old male who 30 minutes ago was crushed by a van against the wall. He's got head, chest and pelvic injuries, and he's got an amputation of his left lower leg. He is unconscious and shocked with a heart rate of 120. Blood pressure is apparently 150 but with a weak radial and SATs of 84. He's currently got an OPA in, cervical collar, pelvic binder, tourniquet on leg. He's got one IV access. The crew are just doing a scoop and run and they'll be here in 10 minutes. Everyone understand that? Any questions? So this guy sounds big sick, sounds like he's going to need to go to sleep.
Yeah,
pretty sure after arrival.
Okay,
if you guys
we'll
can
get ready for our side.
sit up that.
Yeah.
If you can prep the Belmont, then that will be fab. Craig, if you can go to the lab, once we've finished here, I will phone and activate the major hemorrhage protocol. Lucy, if you can be Doctor 2, if you can check pelvic binder and then do C, and Denise, if you can do my B assessment, then that would be fab. And yourself, Tamsin, if you can put monitoring on, clothes off, that'd be great.
Yeah.
All right, everybody happy with that? Excellent. Thanks very much.
Do you want a pre-alert CT as well?
Yeah, I'll give CT a call just now.
Great, thanks. Tamsin, can I get the RSI drugs?
Yeah.
Thanks. Okay.
After the brief, there should be a lot of activity from all members of the team preparing the resus bay, all the monitoring and equipment, checking the airway equipment and the ventilator, and potentially drawing up anaesthetic drugs and emergency drugs for rapid sequence induction. Intravenous access kit can be prepared, blood bottles and forms can be prepared ready. If major hemorrhage is suspected, then the major hemorrhage protocol can be activated and blood can be retrieved ready, and the Belmont can be prepared ready. Remember to have the Wolfson mattress ready and also the bear hugger. If possible, use the one that can be placed under the patient because keeping trauma patients warm during a trauma is a challenge. During this time, the trauma team leader can stand back and observe the team, making sure that all team members are being utilised effectively and that no one member of the team is being overloaded. They can also make sure that all team members have signed in on the trauma paperwork.
You keep all the apples and I'll double check.
You guys happy?
Yep, happy.
Once equipment and drugs have been checked, the anaesthetic team can go through the RSI checklist to make sure everything has been covered and to talk through a plan before the patient arrives.
Okay, so any additional help required? No, I think we're okay, aren't we? Consultant Resus, I'm here. Role allocation, Pete's going to be team leading. I'll integrate. Bernard, I'll get you to do cricoid as well. Monitoring, so capnography, capnography here. Can I attach that onto the filter ready? Just check that's working. Yeah. Okay. Oxygen saturations, ECG.
As you can see in the video, one of the team members is having problems setting up the Belmont. The team leader spots this and goes in to help with troubleshooting.
Okay. So first
This is
part
good
of monitoring
leadership.
I'd like on is the blood pressure if possible, and put that on the 2-minute cycle too. Bernard, intubation equipment.
Going through the checklist allows the team to make sure that all the equipment that they might need is present and that the team members know where to find it. It is a lot easier to do this before the patient arrives than in the middle of managing a sick patient.
We've got Goodell, we've got an iGel, size 4, yep. Got suction, yes. Okay.
Just before the patient arrives, maybe at the point you hear that the ambulance is pulling up, the trauma team leader should bring the team back together for a final brief. They can ensure that people are ready, everyone has PPE on, drugs like tranexamic acid are drawn and ready, and things like the Wolfson mattress and pelvic binder are in place. The oxygen should be connected and on, and suction is on and ready. They can talk through their plan for what to do when the patient arrives. Most of the time, the plan will be a 10-second check on airway, pulse, and any catastrophic bleeding, then transfer the patient across to the ED trolley, and then everyone listening in for the ATMIST handover. If the patient sounds very unstable, or the pre-alert is unclear, then it may be worth discussing in advance a plan B option. What the team will do if the patient arrives in cardiac arrest, for example. Planning ahead for this will make the team much more effective.
Major hemorrhage has been activated, CT are pre-alerted. If we can hang the blood but not spike it, because we'll just see what he looks like when he arrives, but then it's checked and ready to go if we need it. So just to recap goals, because this person should be with us any minute. Scribe, you're happy?
Yes.
Non, you're happy with Belmont? Bernard, Mark, you're happy, ready to RSI on arrival if necessary. Denise, B, and if necessary, chest drain.
Yep.
Lucy.
Yep. Check C and IV access ready to go.
Excellent. Can I also give you the job of checking the tourniquet when he gets here?
Sure.
Excellent. And put clothes off, monitoring on. Runner. Surgeon standing by.
Yep.
Excellent. Any questions?
So when he arrives, we'll do a quick 5-second check. Check his breathing, got pulse, get him across, and then have handover.
Yeah.
When the patient arrives, greet the paramedics and then the team should do a quick 10-second check, led by the trauma team leader. The anaesthetist should confirm whether or not the patient has a patent airway. This is just to check that there is nothing that needs to be addressed immediately. A patent airway doesn't mean it has to be perfect. As long as the patient is breathing or can be ventilated, then that is okay. If they have already been intubated, then this check should be a confirmation that there is end-tidal carbon dioxide trace. One person can feel for a central pulse and confirm that they have a pulse. If there is no palpable pulse, then the team need to immediately activate their traumatic cardiac arrest protocol. If there are significant limb injuries, someone needs to check and confirm that there is no catastrophic bleeding. The majority of the time, there should be no immediate issues to address. The team can then transfer the patient onto the ED trolley. Once transferred, then all the team need to be quiet and listening to the at-mist handover from the paramedics. At this point, do not cut clothes off or attach monitoring. These things are distracting for the team, and you may miss vital bits of information that could help you in your treatment of the patient.
Hi, David.
Hello.
Excellent.
Hi there. How you doing?
Mark, just going to do a quick check.
Okay, so he's unconscious, he is breathing, I can feel the carotid pulse.
Excellent. Can you check the tourniquet?
Okay, do you want to get him across behind over?
Yeah, let's get him across.
On its working.
Tourniquet's fast.
Okay, so on my count, the command will be ready, brace, lift. Is everyone ready?
Yeah.
Ready? Okay, ready, brace, lift. And down.
Okay, trolley out and hand over, please.
So we've got a 20-year-old male hit by a van about 40 minutes ago, crushed against a wall. He's got significant head, chest, possible pelvic injuries, and he has a traumatic amputation of his left leg. In terms of signs and symptoms, he's got oxygen on, he's unresponsive to pain, he's tolerating a Gadell. He deteriorated en route, reduced air entry on the left-hand side, so I've had to decompress the left side. His SAT's now at 90% on oxygen. His blood pressure has deteriorated as well. He's tachycardic 150, blood pressure 98/63. He's had a gram of tranexamic acid, he's had 500 ml of crystalloid, he's got a pelvic binder, he's got a tourniquet in situ, and oxygen.
Excellent. Thanks very much. Good work. If you can book him in, then come back just to clarify a few things with us.
So the next stage is going to be the primary survey. What we're teaching on this course is rather than assess airway and then breathing and then circulation and then disability, which is the way to do it when you only have one person to do the primary survey, you can utilise all team members and assess the patient together. This is taught by the European Trauma course. This should be more efficient as it utilises all team members. The anaesthetist is best placed to assess airway and also disability, assessing the GCS and pupils. They can also ask about pain, and also take a history from the patient, asking about allergies, medical history, medications, and the memory of events leading up to the trauma. One of the doctors can assess breathing and chest injury. Pay particular attention to rib fractures, any flail chest, and any chest wounds or bruising, the respiratory rate and respiratory effort, and any evidence of pneumothorax or hemothorax. Another doctor can assess circulation, paying particular attention to the heart rate, skin or mucous membrane colour, temperature, capillary refill time, any abdominal pain, swelling or bruising or tenderness. Do not spring the pelvis. Examine the pelvis by looking for bruising around groin, the scrotum or the pelvis. Gently feel the iliac crest and the greater trochanter, looking for tenderness, and look at the leg position. The trauma team leader should give the team enough time to complete their assessment and then ask for the findings, in order starting with airway. Everyone should know their role, so there should be little reason for talking. The only communication should be the anaesthetist talking to and reassuring the patient, and then the team members feeding back to the trauma team leader with their findings. Speak loud and clear when you do so that the whole team can hear you. The scribe needs to record all of your findings from the primary survey, so the scribe may ask you to repeat or clarify any points. It is helpful if the scribe prompts for any missing information. For example, if the team have forgotten to assess the pupil sizes, then the scribe should be assertive and ensure that this gets done and is recorded. This is why the scribe should be someone relatively senior and experienced. Note during the primary survey that the team are quietly getting on with the tasks that they need to do, and only one person is speaking at a time.
Okay, so he's got a Gadell in, he's tolerating that, he's completely unconscious. GCS, as far as I can see, is 3. He's not responding to pain at all, no verbal response. Pupils are 3 millimeters left and right, equal and reactive. So we'll prepare for an RSI and let you know when we're ready.
Excellent. Okay, Denise.
B, trachea central. He's got no crepitus, no flail segment. He has a needle in the anterior left chest and reduced breath sounds and bruising to the left hemithorax.
Noted.
C, he's got bruising over the left side of the abdomen. The abdomen does feel soft. He's got a pelvic binder in, but it is riding high at the moment. It needs to be brought down. And as I say, he's got a tourniquet on, but it is holding.
Okay.
IV access
RS
is coming in
150.
here.
Blood pressure is 112 over 39.
Okay, obs noted. If you can spike that blood, if we can give the first unit through that cannula as bolus. Lucy's getting access and we'll get bloods including cross-match off to the lab to get the rest of the major hemorrhage protocol activated. Let's prep for RSI, go through the checklist.
The whole primary survey should only take about a minute. After the primary survey is done, the trauma team leader should then summarise back to the team and make a plan. There will be a few joint decisions that need to be made, and this is what we call the command huddle, because the key people who need to make these decisions need to talk them through together. Generally, the key people will be the trauma team leader, the most senior anaesthetist, and the surgeon. The first decision that needs to be made is whether the patient needs to have a rapid sequence induction, for example for airway protection or neuroprotection, or because they are combative and agitated. The plan of how to do this and what other actions need to be taken can then be discussed with the team. The second main decision that needs to be made is the direction of travel. Is the patient going to the CT scanner, and what needs to be imaged? Generally, most of our trauma patients will go to CT and have a full head to pelvis trauma scan. The team also need to discuss where the patient might go after CT so that forward planning can start. For example, pre-alert in theatres, or starting to plan for potential transfer out to the major trauma centre. This is not a time for the rest of the team to switch off. Be proactive team members. For example, the scribe can start filling in the CT request form. Team members can start preparing for rapid sequence induction or chest drain or any other procedures. Team members should speak up if they have any suggestions or if they've identified any potential problems or snags with the plan.
Okay, so to summarise, this guy's big sick. He's clearly got a head injury. He's got chest, possibly abdominal pelvic injuries, traumatic amputation of this left leg. He's hemodynamically unstable. So the plan will be to get him off the scoop. We'll adjust that binder. Then we'll go through our pre-RSI checklist. Okay. Whilst he's getting his proxenation underway, as soon as he's off to sleep and the tube is secure, then Denise will ask you to put on a chest drain in that left side. Okay? Everyone happy with that?
Yeah. Are we ready to get him off the scoop? Okay.
We'll just secure this line before we get him off the scoop.
Yeah. If we take the blocks and tapes off burners. Okay, so I'll coordinate getting him off the scoop. Can I have 3 people down this side, please? And then, Denise, would you mind giving a hand just to get him off the scoop to begin with? Okay, 3 people in place. So we'll roll to the right, just 15 degrees. Take the left side of the scoop out, and we'll roll back, and then reverse to get him off the other side of the scoop. Okay. So, on my count, ready, brace, roll. Ready, brace, back. And 3 people on the left now, please. Okay. Ready, brace, roll. And ready, brace, back. Okay. So, Lucy and Denise, do you want to sort out the pelvic binder while I'm getting ready for RSI? Pete, would you mind doing the RSI checklist, please?
We'll just go to the level of the gross retentive.
Okay, Mark, you have to go through the checklist while these guys are doing this?
Okay, I'm happy.
Righty, any additional help required?
No.
No. Allocation.
Okay, so your team leader and I'll be intubator. Bernard's going to do cricoid and intubation assistant. Tamsin, are you happy to give the drugs?
Yes.
Yeah. And I'll need someone to do Mills.
Yep.
Are you happy to do that? Do you want to come around this side? Is that all right?
Okay. Is cardiovascular status optimal?
No.
Yes.
I think
Then I'll take the collar off.
he's still quite shocked. So if we could give him another couple of boluses of blood before we go off to sleep, please.
Okay. GCS.
So
Pupil
GCS
size?
is 3, pupils are still 3 millimeters and reactive.
Okay, anticipated complications.
So he might crash on induction. If he loses blood pressure, I just want to push the blood as quickly as possible.
Okay.
And he may have a tension pneumothorax on the left, so we're going to need a chest drain as soon as the tube's in.
Okay, as soon as we got 3 lots of CO2 on the monitor, Denise, as soon as Mark gives you the thumbs up, we'll crack on that train. Okay. Happy with the position? Optimal?
Yep.
Could we have his left arm out of it so I can get him?
We'll do that as soon as the tube's in.
Okay.
Preoxygenation. Yeah. We're on 100% oxygen. Yeah.
High flow nasal oxygen on.
Yes.
Drugs. Induction agent.
So I'm just going to go with 50 micrograms, 1 mil of fentanyl, 50 milligrams, 5 mils of ketamine,
Muscle
and
relaxant.
rocuronium, 100 milligrams of 10 mils.
Okay. If at all possible, try and avoid vasopressors with him. I'll give blood if he crashes.
Okay.
Monitoring CO2.
Yes, we've got
is
CO2.
Present. Saturations.
Saturation is 92.
ECG.
ECG, heart rate's 150.
And blood pressure set at 2-minute intervals.
Yeah.
Okay. Happy with the intubation equipment?
Yes.
What's your plan A, B, C, D?
So my plan A is going to be Mac4 blade with a bougie and a size 8 tube. Plan B, if we have difficulty, is go straight for an iGel size 4. Plan C will be a Goodell and face mask, and Plan D will be front of neck access, which is in that bottom drawer.
Okay, who will do front of neck access?
I will do that.
Okay, I will prompt. Everyone happy to proceed?
Yes.
Excellent.
Okay.
Happy with the Belmont?
So crack it on, please. Tamsin, could you give the fentanyl first, please? 1 mil or 50 micrograms.
Yeah.
Okay, ketamine next, please. 5 mils. 50 milligrams. Scribe, have you got that? Yes. Yeah. Okay. And rocuronium, 10 mils, 100 milligrams. Has he had TXA?
He was given TXA by the crew. We'll give the infusion when we get back from CT.
So. Okay, I've got a good view of the cords. 2, please. Okay, I've got the tube. Okay, bougie out, please. Cough up. So we're 24 at the lips. 1, 2, 3. Okay, we've got capnography. Crack it off, please. Bernard, if you could then connect the ventilator, please. And pass me the Thomas tube holder.
Okay. If Lucy can adjust your position so that Denise can get into that chest drain for us.
Okay, so we'll do the blocks first. Okay, Lucy, you can go hands off. Thank you.
We go post-induction blood pressure.
If you hold the arm out, just pressing for blood pressure. Yeah, it's taken now. If you could connect the ventilator up for me.
Cut shots. Skin is cut. Blood dissecting. Okay. Finger in, lung is down,
Lung is down.
drain is in. Drain is connected.
So, surgeon here? Okay. Mark, you happy with the top end?
I will see.
Yeah, tube secure. We're on the ventilator. CO2.
There's an air entry.
We're at
Air
4.0 at the moment.
Do we keep an eye
Air
on
entry.
ice, or can we cover it?
No, I want
Air
that's
entry.
it.
I'm hearing air entry in all zones of the chest. Okay. Excellent. So, you just see the post-induction blood pressure?
Post-induction blood pressure is 108 systolic. Heart rate's still up a bit. I think another push of blood and we'll give him some more fentanyl.
Okay.
Another
So,
1
to
mil of fentanyl.
So to
please.
summarise, where we're at, now intubated, ventilated, we've got closed head injury, we've got thoracic injury with a chest drain in situ, which is bubbling. If you can just put that chest drain bottle on the floor, then that'd be great. high likelihood of an abdominal injury given that bruising is cardiovascular status, likely pelvic injury, pelvic binder has been readjusted. He's got a traumatic amputation of this lower left leg, the dressing in the cat is holding. Okay, so I think he's stable enough to go for pan CT. Do you agree?
Yes, I think so. Yeah.
Okay. You happy with that?
Yes, I agree.
So plan will be, we'll prep to go to CT, we'll get that second bag of blood in with them through the warmer before we leave. We will aim to leave within 5 minutes, so if you can prep for transfer monitor, we'll get packed, and if you can give CT a call and let them know that we'll be leaving in 5 minutes, that'd be great. Okay, stop
Could
that
you
now.
pass me the checklist and we'll go through the post-RSI checklist? Okay, Bernard, so we'll go through this together.
Yeah.
So, end-tidal CO2, trace,
Yes,
target end-tidal CO2, we'll aim for 3.5 kilopascals.
You happy with all that?
So, oxygen saturations are 98, bilateral breath sounds, Denise has already examined, ETT length is 24 centimetres,
Yes.
tube is secure, chest drains in,
Yes.
C-spine is secure,
Yeah.
sedation, can we have that propofol running please at 20 mils an hour to the syringe driver? So target blood pressure, Pete thinking because of head injury but he is bleeding, we'll aim for a systolic of 100 to 120 or a mean of about 80.
12,
I think that's reasonable.
So
Okay.
he's a little bit low present, but we've still got this blood to go through.
Give him another bolus of blood, please. We've got 2 IV access. Pupil size is still 3 millimeters and reactive. So we're doing neuroprotective measures, and we have some more rocuronium. Could you draw up another 10 mils of rocuronium, please? Monitoring is on. We've got capnography, SAT, TCG. Blood pressure's on a 2-minute cycle. Okay. Bernard will take the laryngoscope and the airway roll.
Yes.
Okay, we're on the Wolfson mattress. So plan after CT. I think we'll just see what the CT shows.
Happy with that?
Yeah. Okay. Bear in mind, so options are going to be either go straight to theatre, or we'll come back here, and then it might be a critical care transfer to Stoke.
I think plan A will be to come back to Resus.
Yeah. Are we happy to go?
CT are away already.
Okay.
Thank you.
Right. If we just load the ventilator on, and then we'll go to CT.
Remember, the trauma team doesn't finish when the patient leaves to go to CT. The patient will probably come back to the emergency department, but then they will need to go somewhere else. We still haven't actually treated their injuries yet, so some of the team will need to escort the patient to the CT scanner. The rest of the team can stay behind and help prepare for the next stage, for example getting ready for transfer. Things that they can do include preparing an arterial line, preparing a urinary catheter, getting the transfer trolley ready, preparing syringe drivers for sedation, and preparing the paperwork. Don't just walk away and think the job is complete. The real work is only about to start. If the patient is going to be transferred out, there will be a lot of tasks that need doing before they are ready to go. They will also need a thorough secondary survey. This is often forgotten, and it is often assumed by the receiving hospital that it has been done. Things like broken fingers or dislocated shoulder can be missed because they weren't picked up at the primary survey. But these things can have long-term, life-changing consequences for the patient. The patient will need to be log-rolled so that their back can be examined, and a PR should be done if these have not been done already. If the patient has spinal injuries, an ASIAS chart must be completed to document a thorough neurological examination. One person needs to take responsibility for a thorough secondary survey and documenting findings. If the patient is truly time critical and this is not done, then hand over clearly, both verbally and in the notes, that the secondary survey is not yet done and needs to be completed. The patient may need invasive monitoring such as an arterial line. They may need more intravenous access. They will probably need a urinary catheter, and they may need infusions prepared such as metronamnol, tranexamic acid, propofol and alfentanil. They may need to be washed and any superficial wounds dressed. The monitoring will need to be transferred to the transfer monitoring, and the patient will need transferring onto the transfer trolley. All of the documentation will need completing, and all drugs given need to have been prescribed. All of these things can be done efficiently if there is a team of people working effectively under the leadership of the trauma team leader. In these videos, we've broken down the first stages of the trauma team and shown how the team can work effectively and efficiently to complete a lot of complex assessments and tasks in a relatively short time. If you were to replay these videos without the pauses, then you'll see this patient was seen immediately by a consultant, had their first unit of blood after 3.5 minutes, and had a rapid sequence induction complete within 10 minutes of arrival, and was ready to go to CT in less than 20 minutes. This is to show that these things are possible, but only by focusing on these elements of team training. Anticipating and planning ahead, and good leadership by the trauma team leader, and good followership by the team members. Use of good communication techniques, and everyone using the same standardized approach, using standard operating procedures and checklists, and good shared decision making. The leader always trying to maintain flow and momentum with directed team goals. As we said before, the best way to learn these techniques is through regular practice in simulations in your department. Thank you for listening to this talk.